Welcome to the latest episode of Mic'd Up with ChiroUp. I'm your host, Steele, and today we're going to go through three things that I think are pretty interesting. One has been, I guess, a revelation, as I could call it, for my clinic, Premier Rehab, and it goes through after realistically years of training new associates and refining my own and also their own report of findings. I'm kind of excited to share with you a strategy that has brought some recent success to our clinic. So that's number one. Following that discussion on report of findings, we're going to dive into a new chiropractic toolkit on heel pain, which is going to be released to all of our subscribers. However, heel pain is a significant issue, and I found that successful treatment hinges on the accurate diagnosis. So I'm going to guide you through an algorithm that's going to take you about a minute to develop the most sensitive and specific tests that are common for heel pain diagnoses. And then not only are you going to get that information today, but you'll be getting that as a ChiroUp subscriber as far as a toolkit. And I'll explain that when we get to that section in the podcast. Finally, we're going to turn to our sponsor, which is us, to tackle one of the most frustrating aspects of the chiropractic business, which is reporting. I am on my fifth EHR, and reporting is by far the most frustrating. And it's tedious. However, it is one of the most crucial parts of any kind of chiropractic practice. It's an important measure. So it's one of those things that it measures how well we're doing in practice, and we need to make sure that we have those numbers for not only our practice, but also for our associates, also for our accountants. And I'm going to demonstrate a new piece of functionality that I believe has been significantly helpful for our clinic, both for just having the right numbers, but also it's going to actually save us money in the long run. So we'll go through that at the very end. Before we dive into the meat of the podcast, once again, if you haven't liked this podcast, if you haven't shared this podcast, please do so. It's the only way we can get our name out there as far as evidence-based chiropractic and how to do things right in practice to help, help a ton of patients get out of pain and help them through their journey with whatever problem you're solving. And two, just kind of change the perception of where our profession is going. And I think this podcast is going to highlight several of those things that chiropractic clinics are doing around the world to help a bigger piece of the population. So first, this is probably the most frustrating thing in practice, at least at the very beginning when you're working with associates or when you're working with other people in your practice. And really it has to do with when there's a hole in your bucket. And in other words, what happens when you've mastered getting patients in, you've mastered the patient acquisition, you've even, you're nailing the reactivation, but patients still are not following through with their treatment plan. Premier Rehab, which is Dr. Berlesman and my clinic, we really have developed a way of doing this that has nothing to do with selling more visits. Instead, it's really about reshaping how you communicate with your patients from the very beginning. And Dr. Reverman, who's also an Illinois chiropractor, told us a long time ago that an educated patient is a compliant patient, which is an interesting phenomenon because most chiropractors want more compliant patients, meaning they're going to follow through with your recommendations. So in this section, I'm going to share with you a simple, a proven strategy that really leverages informed consent. Yes, I said it. The one thing that my new docs have difficulty with, informed consent, and how we're going to use informed consent to boost our patient's understanding and to elevate our value in the patient's eyes and to really ultimately improve patient compliance, leading to better outcomes and a smoother road to recovery for both the patient and the provider. Now, that's my kind of take on it, but the research really calls this shared decision making. I call it empathy, but research calls it shared decision making. And it really works. And I'll give you a study. I'm going to show you an example and then really kind of dive into how I do this on an individual basis. However, shared decision making is when a patient feels the plan, your treatment plan, reflects their goals. And it's not your plan, it's actively chosen. When you have shared decision making, it's you and the patient deciding on a plan that makes sense. And what they find in the research is if they're a part of that decision-making process, they're more likely to follow through. So do me a favor, hit pause on the podcast after you hear this paragraph and think about this and actually try to do it. Can you clearly recite an individual care plan for a 30-year-old carpenter with recurrent elbow pain from lateral condylitis in less than 60 seconds? Think about that. Try it. Pause. Now, if you did that exercise, try to do the same thing for an 18-year-old student with cervicogenic headaches and it's preventing her from going to college. And then do that for lumbar spine stenosis. And what you'll come to realize, and what I've come to realize, is it's not easy. Not only do we have to be able to understand those conditions, but we also need to speak to them on a level, as far as comprehension, that makes sense to them. And really, that's the point, is that a report of findings is difficult. However, when you can deliver a unique report of findings for each condition, and more importantly, for each patient, it takes real effort. But that effort it's what separates average outcomes to exceptional ones. Because when patients come in with a problem, yes, we need to provide that solution, but we really need to make it individualized to them. Because if you give the same canned report of findings with the same generalized care plan, with the same potential results, your results, as far as your compliance, is going to look exactly the same as it did last month, and exactly it did the month before, and exactly the month before. I believe, in what research shows, if you can change your report of findings and tailor your informed consent, and I'll show you how to do that, to each case, you're actually going to improve patient compliance. And then, I guess, ultimately, your clinical results. So stop doing that canned response, and let's start making a better decision on how to educate our patients. So let me give you the research first, because meta-analysis and systematic review show that shared decision-making processes improves patient knowledge, increases patient engagement, and at the end result, improves downstream adherence and implementation of whatever those options were. So whatever you're recommending, I want you to do exercise. I want you to do some, extension exercise. I want you to stop sleeping in that position. I want you to stand a different way, whatever it may be. And if we can make a clear explanation of why that's important, it's going to help them understand why it's so critical to their care. Now, when it comes to informed consent, there is a little bit of variance based in your state, so I'm not going to give you legal advice here. However, most of us try to do this both in voice and electronically, or for those of you still doing paper. So we can have a consent document. Now, our consent is all electronic. It's all signed before the patient walks in the door. However, have a written, signed copy of your informed consent. And not every state requires that. However, it's good to have just for to make sure that we have it in writing. And you should make it verbal and include it in your SOAP note. But in an informed consent, you really want the nature of the treatment, so what you're recommending, the risks, the benefits, the alternatives, and the expected outcomes. Now, that's a difficult thing to happen in your first visit, but we have to do it. And the way you do it is so important. And the reason I say that is because there's other companies that do that, and it drives me insane. So let's imagine you're watching a TV commercial, and you see a commercial for a pharmaceutical drug company. What are they going to do? Are they going to slowly go through all the side effects of that, the the risk associated with it, or do they quickly go through it, expecting not to really get any questions? So yes, we have to have those risks associated there. However, not many people are going to read your document, your informed consent document that you have, or consent to treat document you have for your practice. So the reason I bring this up is because that if you give a 10 out of 10 informed consent conversation within your first visit or two, this is where the magic happens. Now, to give all these things in that quick of a time does require a little bit of skill, but I think of it as a simple time frame. An acronym like BRAN, B-R-A-N, which is essentially I need to go through in my brain. I'm thinking B, benefits, R, risks, A, alternatives, and then N, which is by far the most important one. What happens if we do nothing? So whenever we can get these completely done, I really consider this a compliance builder because I'm bringing in some confirmation. They understand what I'm saying. I've given them an out. I've given them other things to do. And they said, no, I'm going to go with you on this one. When I went through the research, and I always like to pull out a little bit of research, but there was a good article, I think it was Psychotherapy and Psychomotor Journal in 2008, says that really for any suitable long-term decision, it has to be a shared decision model. So whenever you have in a situation of chronic pain, chronic illness, for any intervention containing more than one session, you can sell most anybody on something, but if you want them to keep coming back because they need the treatment or they need something from you, it requires them to have some kind of understanding and buy-in to what you're selling or what you're providing to them. Now, when it comes to us, I think there really are three things that have to happen. So yes, we need to give them the brand. We need to understand the benefits, risks, the alternatives, and if we do nothing. However, during that conversation, we have to instill three things. And I consider this my financial investor, meaning money is important to each and every one of us. However, have you ever thought about this? What is even the name of your financial investor? And why do you even give them money? And probably even more importantly, why do you continue to use your financial investor when something like money is so important to you? So I'm going to kind of use that example when I talk to you about, chiropractic, because it's interesting because whenever I think about my retirement, I have an idea of retirement. That's my goal. And with our patients, we have to connect their goals to what we're trying to accomplish. So I'm not going to invest in a 401k without believing in retirement. In the same way that patients are not going to commit to 6 to 8 visits with you unless you plan on getting them to a goal. If they don't believe that you can get them to the goal, they're not coming back. The second part about investing is make the plan concrete. Meaning, if I have an idea of what compounded interest is, I have an idea of what timelines are, I get a statement from my financial investor on a quarterly basis to show us progress, well, that instills a little bit of trust in him or her. That tells me that this person has a plan, they're showing me progress, and I can understand why I need to stick around with them. Well, the same goes for you. As a provider, if you have a treatment frequency, if you have home strategies, if you tell them from the very beginning there's going to be ups and downs, but then we're going to reevaluate and change as you're progressing, patients understand that. But if we don't make that plan concrete in a report of findings, that's when people are going to get lost and not understand why they have to come back. And then I think the last one, which I do think goes without saying, but I'm going to bring it up. Nobody invests with a financial planner they don't trust. And that has a lot to do with providing the same report of findings for every patient, for every condition. Because we have to make sure that we're listening to them. We're listening to their concerns. We're adjusting the plan based on the curveballs they're throwing at us. Yes, I have lateral but I'm a painter. But I lift competitively, lift the weights competitively. So we have to make sure that we understand what they're trying to go through, that we're a trustworthy person, and that we're going to create a solution for them. Now, let me give you a real example, because this is kind of where the rubber meets the road, is that after you go through, obviously, your physical exam, after you do any kind of testing that you're going to do on that patient, after, the subjective is taken, a history is taken, what does this actually sound like? So if I have that patient, I think I said something about meat-up condylitis in the example that I brought up before, but it would be something like this. Hey, Johnny, given your goal of getting your elbow back to 100% better, let's kind of work on this plan together. I'm going to recommend some manipulation, some manual therapy, and some shockwave treatment. You're going to do exercises A, B, C, and D. I'm going to give you these exercises in an email format. You'll have pictures, videos, and descriptions on how to do those. And Johnny, I need you to do an activity modification. I'm going to need you to wear this brace. I'm going to need you to stop doing X, Y, or Z. Now, if you can do all these things, I can get to your goal. Meaning, if you can get these recommended management selections, I can do these treatments, we can do these exercises, and you can change these activities of daily living, I think I can get you back, this tendon in your elbow, back to normal within about 3 to 4 weeks for full recovery. I need to get things loose, you need to keep things loose, and we need to prevent re-injury. The other options are I can send you back to your primary care doctor for a second opinion. I can send you to physical therapy, or we can do nothing and we can see how it heals by itself. But based on what you've told me from your condition and based upon my knowledge of this elbow problem, I recommend 2 times a week for the next 4 weeks, and we're going to solve this problem together. Does that match what you want? That simple explanation, while it is tailored to an elbow, is the gist of what I can give to every single one of my patients. And I get buy-in. After 15, 16 years of doing this, I've never had someone say, no, I'm going to try physical therapy. Or, you know what? I don't want to do this. I want to go back to my medical doctor. If you can provide that response in a very trustworthy, a very confident manner, they're in your office for a reason. They want what you're about to provide to them. Now, it's simple, so you and I know where these recommendations are coming from. You and I know which treatments are the best for every condition because we have the condition reference section in ChiroUp. You and I have the best treatment strategies. You and I have the best exercises, programs for these conditions. It becomes very simple to provide this report of findings in this fashion, and your compliance is going to go up, your adherence is going to go up. Now, if you have any other recommendations or like pearls on this, let me know. Brandon at ChiroUp.com. I'd love to hear how you're getting better results, because this is one of the number one challenges that I hear from subscribers is, what is your report of findings? How can I make mine better? So I thought I'd bring it up on this podcast. Now, for the clinical stuff, because this is kind of the stuff that we were centered on as far as chiro from the very beginning. This is the stuff that gets me excited as far as solving problems for patients. I do want to go through a region, not necessarily a diagnosis, but a region, because, treating conditions is, it's not easy. I'm not going to say that, but it is fairly standardized these days. We have good research to support or refute a lot of, single treatments, and we have more of a multimodal treatment strategy for a lot of these conditions that we treat. However, if you have the wrong diagnosis, it really doesn't matter how good you are at soft tissue or manipulation. You have to understand the condition first, and the diagnosis comes first. Adrienne at ChiroUp, if you don't know her, she's one of our wizards over there as far as giving you patient information, educating you on the platform. But she's assembling a brand new heel pain toolkit that I think will come out next week or the week after. And it's really designed to make your evaluations faster and more precise. It's going to give you a standard webinar. It's going to give you a short little evaluation video, some infographics for quick reference, and also go through, of course, the most common orthopedic tests. But I want to give those to you today, because this is one of those things that I just find interesting, because when it comes to especially long-term diagnoses, those things have been haunting our patients for long periods of time. Often it's not the failure to provide treatment from another doctor, another massage therapist, another physical therapist, whatever it may be. It's not a lack of effort. It's that the diagnosis was wrong. So I find this is something that if we can have a better diagnosis, we can, of course, provide the right kinds of treatment. So when it comes to heel pain, what are the most common causes of heel pain? And then how to identify those? That's what I want to go through right now. Number one, of course, the number one heel pain that we're going to see as far as prevalence in the U.S. is plantar fascial pain. And when it comes to that, the windlass test is probably the most common and has really good specificity. Now, I've seen this performed multiple ways. Of course, you can look at the video, go in the clinical evaluation section in ChiroUp and type in windlass test, and it'll give you how to perform this test with a video. However, I've seen it both just standing up, or you can stand on a step with your toes off the step. I don't have too many steps in my office, so I really can't do that. So I just have a patient stand up next to me. And then what you're going to do once they have their weight on that affected foot is the clinician, or you, is going to passively dorsiflex that big toe, essentially. So with weight bearing, going through dorsiflexion, a positive test is when you get reproduction of focal heel pain, and it's almost always on the medial aspect of that heel. Now, this test, just in isolation, has high specificity, near 100%, but kind of lower sensitivity, around 32% for plantar fasciitis. And now when you combine that with palpation of the medial calcaneal tubercle, which is the inside part of the heel, and a patient history, meaning hurts more in the morning, hurts worse at the first step, we can be pretty confident we have plantar fasciitis. It brings up a common thing, and even I didn't write this down, but I probably should have, because I still, 16 years out, this is pretty embarrassing, but it is what it is. I still have difficulty separating specificity and sensitivity. I know that sounds bad as a clinician, but you don't dig in the research enough, and I don't think about it enough. So let me just reiterate that again. High specificity, and you know what, I'm going to give you an acronym at the end. High specificity, clearly I can't even say it, is when the test is positive, you can be pretty darn sure the condition's really there. It's kind of, I think of it as a truth detector. When it lights up, very rarely is it going to give you a false alarm. So layman's translation, a positive test is pretty trustworthy. It means they have the problem. However, when it has low sensitivity, that means the test misses a lot of people who actually have that condition. So if you have a really big fishing net, however, the rungs of that fishing net are really big. Yes, you put it in the water, you're going to catch some fish, but really only the big ones, and the small ones kind of get through. That's kind of what a low sensitivity test is. Yes, I caught fish, but not all the fish. So in layman's translation, low sensitivity means a negative test doesn't rule the condition out. That's when you kind of have to go through the other signs and symptoms to make sure they truly have that condition. The rule of thumb is, at least the way I think about it, and as I was bringing this up in my head, I was thinking spin and snout. So spin is a specific test. When positive, rules in a diagnosis. Snout is a sensitive test. When negative, rules a condition out. So that's the way I think about it. It doesn't mean it's the way you have to think about it, but when I read research, I still have to go through that in my mind. It's kind of like Spanish. I took 5 years of Spanish, and I still have to translate everything to English, and I'll get better, but I'm getting older also. Anyway. That is the most common cause of heel pain, plantar fasciitis. Number 2, though, that is surprising is calcaneal stress fractures, that these actually happen more than we think. Now, we can use a heel squeeze test, and that's when you have the patient seated your spine, and you're just going to squeeze medial to lateral over the posterior calcaneus. So not the plantar surface, but the outside parts of it. Now, if you get a sharp pain, a focal, deep pain that's sharp right in the calcaneus, that's a positive test. This wouldn't be a diffuse achiness, it'd be sharp. And one interesting thing about this test is I went through to identify the sensitivity and specificity. It's not really widely known. And I found a couple of good tests or a couple of good papers on sensitivity and specificity, but really whenever this test is positive and you're thinking this could be a stress fracture, we do want to follow up with an MRI or bone scan or x-ray because of the sensitivity and specificity. Those numbers just aren't published enough. I did find one paper on sensitivity and specificity, but it had to do with Sever's disease. And it was really high. I think the sensitivity was like 97%. And specificity was 100%. So for a pediatric apophysitis population, really good sensitivity and specificity, but not just for an older person with a heel fracture. So there's just something to keep in mind. One of those things we probably want to back up with some kind of imaging. Number 3 is fat pad compression test. Now, if you look in ChiroUp, we call it heel pad syndrome. Actually, Dr. Tom Michaud had a big piece in putting that one together for us. Can't speak enough about him, his knowledge, and also really his contribution to the profession with books and webinars and seminars. Humanlocomotion.com. It's a regular for me. Really think a lot of really good information comes out of that. However, what I've come to realize is those patients that I do, squeeze the heel, and it's more like a bruise-like pain. It's just achy. And for a specific patient population, it's actually just heel pad syndrome. It's a very different treatment strategy compared to, a plantar fasciitis or a fracture. And I think that this is one of those that unfortunately, as we get older, we get heel pad syndrome, and it's often underdiagnosed or undiagnosed. because those people have atrophy within the heel pad due to multiple corticosteroid injections, just chronic impact, increased weight. We find it more with older women, obese adults, people who stand all day, and then of course the people that are just beating it up, the athletes who are running and jumping on unforgiving or hard surfaces. And then of course sometimes people do this themselves. They get continuation of care for plantar fasciitis not going away, and they're doing long-term corticosteroids, which unfortunately can cause heel pad syndrome. Now, finally, I want to get into a test, and which was the impetus behind this entire section of the podcast, mostly because I just really liked the name of it, and then secondary because I did a touch of research on it to better understand it. It's not often you can read a research paper, and at the end, the author's like, well, we're not really sure why this is positive, but it is. And that's the case for this test. So I want to bring it up, and I want to give you my thoughts on it, whether it's correct or not. I mean, everybody, I guess, can have their own opinion. However, it is called the Royal London Hospital test. And to be honest with you, I never heard of this, but it's for Achilles tendinopathy. And yes, there are other tests that we can use for Achilles tendinopathy. Check out ChiroUp. It's in the condition reference section. However, to identify mid-portion Achilles tendinopathy, and instead of an insertional tendinopathy, we can do this test. So what you're going to do is have the patient prone with their ankle hanging off the table, and you're going to palpate the Achilles tendon, and you're going to find in certain points, in this case with a non-insertional tendinopathy, they're going to have tenderness somewhere. The vast majority of cases, 2 to 5 centimeters just above the calcaneus insertion, and you're going to find a spot that really hurts. And now what's interesting is that when you go into plantar flexion, it stays there. So when you keep the Achilles tendon loose or not being taut, it stays tender. But once you move them into dorsiflexion, the tenderness actually goes away. And this is a positive test for Achilles tendinopathy or mid-substance Achilles tendinopathy. It has pretty good sensitivity and specificity. Now, of course, if you can think of other things you would be looking for, a lot of these patients, when they have it for long periods of time, you're going to get some thickening along this tendon due to a failed healing response and obviously pain associated there. So something that I think is kind of cool. Now, what I think is even more interesting is why. Why is this happening? And I don't have an answer, but I'm going to give you what I think is the answer. So the cool part about the Achilles tendon is that it's an intertwined version of the medial and the lateral gastrocnemius. So both of these muscles are going to come into a tendon, and then combined with the fibers of the soleus, which is mostly the anterior portion of this tendon, they're going to wrap around. In fact, they're going to spiral. It's like 90 to 130, 140, 150 degrees. So you're going to get a twisting motion. And this twisting motion is really how you can start to store energy, and it gives you that rebound effect, and why this tendon is so elastic and how it can generate ground reactive forces so well. So one of the things that I think is cool is when you think about that, as far as all these tendons going in together, is that when you go through dorsiflexion, you're going to pull at that tendon, and you're going to change the relationship between all these muscles, that muscle tendon units that are impacting each other. So they're going to slide differently upon each other. So that's why I think it happens. I'm not positive that's the exact truth. However, I think that just by changing the structure, by tensing the tendon, you're going to take away some of that tenderness between those individual fibers of the tendons. So cool test to use, something that I think will work well for you. The last one is my favorite because it kind of incorporates all the tests into one. And I think of it as a realtor discussion: location, location, location. What I normally have my patients do is to hop in place barefoot. And I know it sounds kind of weird, but the vast majority of my patients are younger and more athletic. So I need to load them a little bit more. And what I find is that if I do a hop test and they get pain in the medial heel, I should be thinking medial heel pain, plantar fasciitis. I can do the windlass test. Now, if they are doing a hop and not coming down on their heel, they can do that all day long. if they have heel pad syndrome, because you're not actually impacting that tissue. So they won't have any pain. So if they don't have any pain when I do that test, but then I lay them down and I push on the medial part of the heel, just straight vertical through the heel, and it reproduces that pain, I'm thinking heel pad syndrome. And then of course, if you do a hop test and they have posterior heel pain, for our skeletally mature people, I'm thinking Achilles tendinopathy. For our skeletally immature people, we're thinking more severs. So it's one of those things that you can help make this differentiation. So I think this hopefully can help you with those 5 tests, help differentiate the difference between all the most common causes of heel pain. Now, last section of the podcast is going to be on some new EHR news. Voice to Chart is already out. It is popular. We're seeing about 60% utilization, and really it's only been out for about 3 maybe weeks. So the month isn't even over. I don't even understand how I can practice without it. But push one button, listen to the patient, push another button to stop, and then go about the rest of your note. By the end of the 10 seconds, 12 seconds it takes to generate, it brings back the entire subjective that you and your patient had in the conversation. It leaves out all the other things your patients talk about. It brings in only the thing the patient talks about, not the things you talk about, and only includes the signs and symptoms associated with that diagnosis. It is exceptional. So something to think about. But that's not what we're going to talk today. We're going to talk today about the compensation calculator, because it saves me hundreds to thousands of dollars per year. So how does an EHR save you money is the question I would be asking. And now, in full transparency, we do have a billing company. I love my billing company. My revenue has only increased by having a billing company. One, it's cheaper to have an outside company at like 5.5% as compared to a person in-house 40 hours a week. But that's my specific clinic. I recognize that all clinics are built differently. However, now that I have better reporting on where money is coming from, meaning a granular report that can really dig through every claim and every invoice to understand billable versus non-billable codes, procedures, and services, and can break down the data regardless if it's on a single invoice or a single claim, and start to actually carve out that if you don't use a billing company for PI, work comp, motor vehicle accidents, all the stuff that you did before, if you're still getting payments in from your old EHR, it can carve those things out, and you really can start to understand where your money comes from. It is big. So now what we can also do is identify overpayments from insurance companies. And now when I'm paying my associate, or now when I'm looking at the different services I offer in my practice, I know where the money is coming from. I know who's posting the counts, and it is up to date, and it saves me money. When I go through a monthly report, and some of those some of those posted payments that are coming in are from maybe a motor vehicle accident from 5 years ago, my billing company had nothing to do with that. So that all that money coming in, is for me, not a billable service. Or what about if you use ChiroUp USA? If you don't use ChiroUp USA, it keeps me compliant. It is the number one thing we've done in our office to make sure that we're following all the rules and regulations. And it actually increases patients. Now, when a patient signs up for it, they tell their family, hey, we have this membership here. You should consider also going to the chiropractor. So something to consider. I know it's not part of this podcast. However, it really helps me kind of carve that section out as far as self-pay patients versus all my collections. Because if I have to take all my collection number and give it to a billing company, they're going to charge me a percentage on all my collections. But when I can carve out those pieces that I collected myself, whether it's supplements, whether it's supplies, whether it's products, or self-pay patients, or balance forwards, whatever it may be, those numbers are drastically different, and end up saving me hundreds of dollars a month by just having better reporting. So that is out right now. Take a look at it. It's in your reporting tab. It's called Compensation Calculator. It's something that I think is going to help each and every one of you. Obviously, we still have payment collection and posted amounts and payment, purchase amounts as far as those reports. But this will help you and I just have better numbers. So I hope you enjoyed this podcast. We obviously went over some things in ChiroUp as far as the EHR. We've gone through some heel pad differentiation. And don't forget about the beginning part of this webinar or podcast. The beginning part is I believe, the number one thing you can change in your practice. And it doesn't mean you need to change everything, but think about how you deliver your report of findings. Does your patient understand their condition just as well as you do? And if they do, it's going to give them the reason to follow through with their treatment plan and make sure that we are held to what we said at that first visit. If there's any questions or concerns, you can always email me, brandon@chiroup.com. If there's any complaints or criticisms, you can email tim@chiroup.com. He loves to hear those things. So really appreciate that, filling his inbox with those things. Otherwise, until next month, I hope you have a great month of patient care.